Hi, welcome to today's OBSSR Directors webinar titled Reimagining What's Possible, a Future Where Reproductive Justice is Achieved. I'm Christine Hunter, the Acting Director of the Office of Behavioral and Social Sciences Research at the National Institutes of Health. Before I introduce today's speaker, I want to go over a few housekeeping items. Today's webinar is being recorded, and the recording will be available in about 1 month on the OBSSR website at obssr.od.nih.gov. Today's presentation will be followed by a question and answer session. So all attendees are going to be muted during the webinar and the chat feature is disabled, but questions and comments will be taken via the Zoom Q&A feature. So to ask a question or send a comment, click on Q&A at the bottom of your Zoom screen, type in your question and send. You also have the option to like other questions, and that avoids the duplication of questions. And so the most liked questions will move to the top. Feel free to send a question at any time during the webinar. Following the presentation, OBSSR's Dr. Beth Jaworski will facilitate the question and answer session and ask your questions to our presenter. So with that, I'm very pleased to introduce today's presenter, Dr. Monica McLemore. Dr. McLemore is a tenured professor in the Child, Family, and Population Health Department and the interim director for the Center for Anti-Racism in Nursing at the University of Washington School of Nursing. Prior to arrival at the University of Washington, she was a tenured associate professor at the University of California, San Francisco, and was named the Thelma Shobe Endowed Chair in 2021. She retired from clinical practice as a public health and staff nurse after a 28-year clinical nursing career, and that was in 2019. However, she continues to provide flu and COVID-19 vaccines. Her program of research is focused on understanding reproductive health and justice. To date, she has 94 peer-reviewed articles, op-eds, and commentaries, and her research has been cited in the Huffington Post, Lavender Health, 5 amicus briefs to the Supreme Court of the United States, and 3 National Academies of Science, Engineering, and Medicine reports, and the data visualization project entitled How to Fix Maternal Mortality. So pretty impressive. The first step to stop blaming women, this is part of the National Academies. It was called How to Fix Maternal Mortality. The first step is to stop blaming women. And that was published in the 2019 Future of Medicine edition of Scientific America. So clearly very accomplished. Dr. McLemore was also inducted as a fellow of the American Academy of Nursing in 2019. She became the editor-in-chief of Health Equity Journal in 2022. And with that, it is my great pleasure to welcome Dr. McLemore to present today on reimagining what's possible, a future where reproductive justice is achieved. And with that, I turn it over to you, Dr. McLemore.
Thank you so much for that kind introduction. And good morning, everybody. I am currently calling in from Seattle, Washington, but I will be running right out, and my apologies to you in advance at the end of the session because I have a flight to catch. That said, I will be happy to answer any questions that are not answered live. Either, hit me up on social media. I'm myself everywhere at McLemore MR. Or if you know me, send me an email and I'll be happy to answer your questions. My name is Monica McLemore and I use she and her pronouns, and it's really exciting to be here with you all to talk through something that I think, we need as many brilliant brains around to try and really think about, like, how can we achieve reproductive justice? Like, how can we really get there? And not just that it needs to be done, but how to do it. I also want to be really, really clear. You have my affirmative consent for screenshots and posting. I will make my slides available to the team and they can post them once the video recording is up. You have my consent to do that. So with that, I'm going to try and walk us through a couple of different ways. As a teacher, I said this to my students this morning because today is the first day of class at the University of Washington, that it's my job to try and really activate people to think differently about phenomena. And so I'm hoping I can activate your curiosity to think about, how we have opportunities in our current climate, our current environment, to be very bold and unapologetic about advancing reproductive justice and getting there. So with that, I'm hopefully going to be able to click through my slides. Because I'm in Seattle, Washington, this is the land acknowledgement that was developed with the University of Washington and the tribal councils here in the Pacific Northwest. I won't read all of it, but I do want to respectfully acknowledge the land of the Coast Salish people, as well as the Squamish, Tulalip, and the Muckleshoot nations, because I think it's really important, and they have been stewards of this land. I also would like to shout out a labor acknowledgement from the Pandemic and Racism Community Advisory Group, who work with Black and Indigenous people to acknowledge the labor of kidnapped African people and their contributions to our culture, the economic growth of this nation, and to really, be respectful and mindful of the enslaved people who really, really developed and co-developed this nation. So, a lot of times people ask me, and there was a whole ridiculous thread that was going down on Twitter around positionality and positionality statements. And I think it's very important that we explain, the perspectives through which is no different than a theoretical or conceptual framework that form our views about the decisions that we make in science. So many of you know me. Clearly I'm a Black woman. I was a preemie in 1969, and it frustrates me to no end, given that our maternal morbidity and mortality statistics, as well as our infant mortality statistics, have not budged in those 52 years I've been alive. I'm a childless by choice person. I'm an ex-evangelical. I'm not even the first Dr. McLemore in my family. And on a funny note, I've never been federally funded. My entire research program has been funded by philanthropy and foundations. So for the learners who are on this webinar, the early career folks, you can build out an incredible career that does not sacrifice what my good colleague Dr. Amanda Stevens talks about. We don't have to sacrifice epistemological diversity by only studying things that are fundable or federally fundable. If you're going to talk about reproductive justice, in my view, it is impossible to do that without standing on the shoulders of the people who actually coined a term, especially when many of them are still alive and working to this day. Dr. Tony Bond is a postdoc with me at the Actions Program at the University of California, San Francisco, and I will be bringing her virtually to do some work at the University of Washington, building out reproductive justice curriculum. Many of you will recognize Professor Loretta Ross, who won a MacArthur Genius Award last year. Many of these people on this list are still alive. And so the idea that people talk about reproductive justice without acknowledging their incredible contribution in their work, I think is just really unethical. So I highly recommend that if you do not know these individuals, please look them up and please look up their incredible work that they've done over decades. I've used some terminology, so it's time for me to define it. Reproductive health, reproductive rights, and reproductive justice are all different things. They are interrelated, but they are distinct. Reproductive rights are the legal frameworks, protections that citizens should expect. Reproductive health and reproductive health services provision is, you go in for your breast exam, your testicular exam, your pap smear. It's health services provision, but reproductive justice is actually really different. And as a framework, as an analytic tool, as a strategy, as a theoretical framework, is very powerful in assisting us to understand that reproductive oppression is actually the root cause of many issues, and that we can design our policies, procedures, programming, educational tools using it. And I'm going to hopefully walk you through how to be able to do that, and to then be able to show you how a new future or several new futures are possible. I'm a visual and auditory learner. I figured this out in college. So figures are very helpful. And I want to shout out my good friend, Dr. Joy Perry, who directed me to this figure, which is adapted from a book that came out around the distribution of illness and wellness in society. It's a book that's actually on social determinants of health, came out 20 years ago. I think I have the reference in the slide set. But basically, what this picture means to show you is that social determinants of health are not inherently negative. In fact, this is a social science audience, so I don't know that I need to say this, but I will anyway. The social determinants of health, not only are they neutral, but they're also mitigatable. I actually sat in a meeting with clinicians where somebody told me that it's very difficult to address the social determinants of health because, they're all related to poverty. And I was like, actually, that's not really true. It's the lack of these things. It's a lack of available food. It's a lack of, decent transportation. It's a lack of quality education, but they themselves are inherently neutral, which means they're not plucked out of the sky. In my mind, they are policy decisions, right? I mean, we showed that we could give our citizens somewhat of a living wage during lockdown and our public health mitigation strategies during COVID-19. We sent people checks. So to say that it's not possible for us to provide for our citizens is actually a policy decision. And those policy decisions don't come out of thin air, just like the social determinants don't come out of thin air, right? Power and wealth imbalance contribute to, why we see social determinants of health. And fundamentally, structural racism or institutional racism, class oppression, and gender exploitation and gender discrimination are where those power and wealth imbalances come from. So when you can break it down pictorially to understand the origin story of many of these things, then it opens your mind up to different kinds of solutions and different ways we can think about addressing these things. So my take home points are: the social determinants of health not plucked out of the sky. They are a result of policy decisions. Health disparities arise, which is differences among and between populations, from structural racism, and that health inequities, these preventable, sort of patterns that we see in society, they persist because of structural racism. And I would also say cowardice, right? Because it does take some courage to be able to, say things like, we're never going to resolve the social determinants of health if we don't have a robust social safety net, particularly in the context where immortality is not an option for our species, at least not yet. And so what we're really looking for is a dignified life and a dignified death. So in order for me to really get at how we can reimagine our current environment, I'm going to introduce you to a framework that I've been using that I actually published in the Journal of Perinatal and Neonatal Nursing that basically helps us to understand we're not all having the same conversation at the same time. And how can we all get on the same page when we're thinking about either policy or research or education or clinical practice? So if you need a bio break or to do whatever, the next 4 slides are all from the Merriam-Webster dictionary, so you can take some time to be able to do that. Retrofit has particular meaning to me since I live in the Pacific Northwest and I lived in California for almost 30 years, where I like the third definition. So there are 3 in Merriam-Webster, and that is to adapt to a new purpose or to retrofit a story for a new audience. And one thing that's really important about retrofitting something is the inherent structure as it exists does not change. So when you think about this in the context of healthcare, right? Until we fix healthcare financing, anything that has to do with pay and reimbursement, that's all a retrofit, right? The inherent structure of healthcare financing is not going to change. That's why the Affordable Care Act was insurance reform. It wasn't healthcare reform. It was payment reform, right? So in retrofitting, the inherent structure will not change, as opposed to reformation or reform. There are 4 definitions in Merriam-Webster. And I like the first one because, it has the word removal in it. And a lot of times in public health and health services provision, even in the life sciences and basic sciences, we don't always have an appetite for removing things. And I actually really appreciate the fact that this allows for things to be removed. So separate from retrofit, in reformation, the inherent structure can change, right? But everybody has to agree what the inherent structure is and what that change should be. Reimagine will be very familiar to many people on this call as social scientists. The work that you do is very much around understanding what new futures or what new systems or what new policies or what new workforce, what all that could look like. So we spend a lot of time in reimagining things. And the problem with reimagining things is there's no accountability. Like we can sit and reimagine all day and be on webinars and conferences and whatever. We can talk about the future we all hope to build, that utopia we all want to get to. But then we all that brain trust abandons the people in the now, and that's a problem because they need help, right? So the thing that I've learned in understanding this framework is retrofit, reform, reimagine is a circle. It's not a linear process, and we need all 3 at the same time. The problem is we can't have our brain trust all in one place at one time, because then we're not able to crowdsource important ideas that perhaps need to be really good, like retrofits or reformations. I realize I'm a very good retrofitter. I'm on team retrofit, and it's important that I name that. Why do we think about this framework? Because on the one hand, you could think about retrofit as past, reform as the present, and reimagining as the future, or futures, plural. So you could think about reproductive health as a retrofit in the past. You can think about reproductive rights as what we have in the present, and you can think about reproductive justice as the future. So in my mind, when we want to have a conversation about how can we achieve reproductive justice, my first question is, well, how are we going to get there? So, but you got to know where you are before you know where you're going. So for me, the context matters. When we published this study in 2018, I was horrified. This is with the Birthplace Lab led by Dr. Saraswathi Vedam at the University of British Columbia. Regardless of race or ethnicity, we found that 1 in 6 women, and that's what they called themselves at the time, we did give them an option to use a different term, experienced mistreatment, 1 in 6, regardless of race or ethnicity. And that included like huge violations of privacy, being shouted at by providers, failing to receive help in a reasonable amount of time, being denied care. Like this hurt my heart. But then when I realized that patient mistreatment and clinician burnout are two sides of the same coin, because our workplaces are intensely inhumane. It doesn't work for the patients and it doesn't work for us. So it allowed me to not be in that, like, who are we blaming for this? And to reject that binary, but that it doesn't work for either population of individuals. And so it needs to be reimagined. If some of you may know Katie Casamano, she is a professor at the University of Minnesota. She is a health services researcher and has done a lot of work around, maternal health specifically, and indigenous health more broadly. But she was one of the first people to sound the alarm on the rural closure of obstetric units, but then also just more broadly looking at hospital closures and understanding that, prior to COVID-19, pregnancy and childbirth were the #1 reasons why people were admitted to hospitals and healthcare institutions in the United States. And so that when you close an obstetric unit, you're not just closing, a space for what should be the healthiest people in the hospital, but you also lose the brain trust or the workforce that's associated with that. Right. I mean, when I talked with Dr. Lisa Wolf, my colleague, who was the previous director of research for the Emergency Nurses Association, emergency nurses would send, pregnant capable people and pregnant folks to OB triage. We had built out a one-stop shop for pregnant capable people such that emergent and urgent expertise, was right to OB, and those folks could get appropriately triaged and get the care they needed. But like, what happens to that brain trust when you close an obstetric unit, right? And then what happens when those emergency department nurses and clinicians don't feel competent to take care of pregnant people, because historically they always had the luxury of sending them up to OB triage. Like, people needed to be thinking about that, and we still need to be thinking about that. When we think about, the public cases of, our, Black superstar athletes, or our, like, world-renowned musicians and their pregnancy experiences and telling their stories in Vogue magazine, when we think about all the misinformation and inaccurate information, the decreased access to services, and even my own institution, having websites not being able to appropriately talk about toxemia of pregnancy or preeclampsia, as Beyonce called it. Like, how do we begin to think about this era of misinformation and disinformation? Now we're in the context of Dobbs. I keep telling everybody to stop saying the word post-Roe, because we're in Dobbs land now, and we need to own it, and we need to talk about it in that way. That said, it opens up a couple of different opportunities to think about, okay, well, in reproductive health rights and justice, where are the opportunities? Well, I hope it has opened up people's eyes that we don't need to use false binaries like, anti-abortion or pro-choice or pro-life or pro. That was always a lie that was sold to us, because, the work around reproductive health rights and justice is always more nuanced than that. It always has been. Those were lazy logistical shortcuts that allowed for people to be polarized, to shut down conversation. In the world of Dobbs, we can have a very interesting discussion about what does it mean that in some states, advanced practice clinicians and midwives actually have a wider scope of practice now, because the physician-only pieces are gone in the banned states. They could always see patients in the hospital, at home birth and birth center. So can we have a different discussion about these things, right? That's the opportunity that we now have when you have an event where citizens have lost a right. And yes, that is very frustrating and it's very disappointing, right? But in a country where our rights have always been negative because of the way that our country was founded, right? When you're fleeing a monarchy, it makes sense that you have negative rights, free from, violence from the government, free from, because we were fleeing a monarchy. But like, negative rights are not the same as human rights. And that's one of the reasons why reproductive justice is so important, because it's grounded in human rights, right? That every human has the right to parent, to not have a parent, to raise their children in healthy and safe environments and community, to dissociate sex from reproduction, to be able to discuss healthy sexuality and pleasure and consent, right? That's why grounding reproductive justice and human rights is so important. They're not negative rights. They're things that all citizens should be able to have access to. Okay, recently we've seen criminalization become more of a phenomenon, and this is where I'm really excited that many of the social scientists on this call are really thinking about this, right? Whether it's public charge or immigration policy or crisis pregnancy centers or Title X or looking at the anti-trans and LGBT legislation, right? As we start to think about how all of these things are linked, in my view, it's about criminalizing sexuality. In my view, it is about criminalizing, individuals who are trying to operationalize their reproductive trajectory. In my mind, criminalization has become a way for us to manage social problems because we don't have a robust social safety net. Right. So again, when we're thinking through, let's apply retrofit, reform, and reimagine to get at where the road to get to reproductive justice. Okay. So where we've lost obstetric units, where, Professor Casamano and many other people have documented this, reopen those units, right? This is a place where it's a retrofit because capitalism and healthcare provision in that context requires that there be some, like management of fiscal resources. But obstetric units aren't just fiscally resourced. They're also humans, they're also time, they're also space. So we need to think about allocation of resources differently. What would the reform be? Maybe we need a nationwide training program in emergency departments to make sure that places who historically had access to OB triage will now have the opportunity to have those skills to recognize, early warning signs, of deterioration. We already had a Black maternal health crisis and a maternal health crisis prior to the Dobbs environment. So why not think about what are the simulation and training needs that we need, not just for hemorrhage or amniotic fluid embolus, but also to disrupt racism and to also be able to listen carefully to patients. What are those simulation opportunities and where are the professional organizations that can help us do that, right? The other thing we need to do is why don't we start thinking about ambulatory maternity units, think about birth settings in a whole different way, right? If we're not going to continue to fund the hospital-based infrastructure, acute infrastructure, which is seriously expensive, we also know that pregnancy is not a disease, right? If it can be managed effectively, and everybody's talking about midwives, and let's fund that, right? So as we continue to think about this, or mistreatment, right? When we're thinking about patient mistreatment, the retrofit is let's continue to implement safety bundles and have training around the implicit bias. Let's diversify our workforce and continue to make sure that we have huddles and places where we can listen to patients. Reformation, again, our professional organizations need to be providing simulation. I am waiting for someone to propose that a simulation in real time or virtual reality or whatever at a professional meeting where people can practice skills of upstander, bystander training, right? In real time in a very low risk environment. I would love to see somebody propose that. And then we need community accountability. How are we going to engage the people that we serve as another layer of accountability for hospitals and healthcare institutions? How are we going to do that? And how are we going to get them trained to be able to participate in maternal morbidity and mortality review committees and in our research studies? And how do we help them, using trauma-informed resources to bring forward the brilliance that they already have? How are we doing that? When we think about the near misses, and these are estimated to be about 50,000 cases per year in the United States, right? We have no more near misses than we have maternal deaths. Maternal deaths are still rare events, right? But when we think about, the people who have severe morbidity, right, where they need blood transfusions or, they need another procedure to be able to, stop bleeding or to take care of them, we need to listen and center patient voices. And again, we need to diversify our workforce across several axes, whether it's having lived experience around race, ethnicity, gender, age, right, religious orientation, really thinking through building out a workforce that looks like the people that we serve. This inaccurate, I am really worried about this, especially in the context of, chat GPT and AI and deep fakes and misinformation and all of this. We really need to be able to partner with community based organizations so that we can have authentic information exchange. We need to be building trust with the people that we serve. We really need to be using social media and other kinds of tools, whether it's LinkedIn or Mastodon, YouTube, whatever it is, TikTok, Instagram. We need to be using that for rapid communication. And we need to have some shared agreements around how to use those tools to be able to get evidence and fact-based information out to people. I was on some billboards in 2018 as public service announcements, and a lot of other folks in Repro have been using those as ways to speak directly to the public. We need other methods to be able to do that and be able to collectively do it so that people know where to get evidence-based information from. And we also need to more clearly understand from the research perspective, what are people using and how can we access them in ways that they want to be connected? So there's like a gajillion research pieces to this misinformation and disinformation and building. I don't know how it got muted. In this criminalization piece, I keep asking professional organizations to bring out their code of ethics, because there is nothing in the American Medical Association Code of Ethics, and there is nothing in the American Nurses Association Code of Ethics that say that we need to call the police on our patients. And, I mean, mandated reporting is one thing around elder abuse and child abuse and all these other things. But for people who are being criminalized for either self-managed or for miscarriage or for abortion or for whatever, we really need to remind people what our code of ethics, our professional codes of ethics are. I also think that we really need to start partnering with some of the individuals and institutions. I know this makes me hella unpopular, but the truth of the matter is, in some states, pregnancy help centers and crisis pregnancy centers and other places that have not necessarily always been so truthful with the people that we serve, but will offer things that a robust social safety net would offer. We need to start using the Freedom of Information Act, if they're receiving tax dollars, to be able to provide services for people. We really need to understand some transparency about what information they are providing to patients. Are they contributing to pregnancy related delays in terms of care or sexually transmitted infection treatment? And I really think that we need to start having some very difficult conversations with people in that context. And similarly, I really think we really need to start with our workforce. It's a huge tension to say that we have structural racism and we have structural issues in healthcare, and then try to bring it back to an individual level. But we really need like workforce initiatives that are about cohort hires and groups of people, and really trying to change the people who are trying to work while also changing the systems that people are working in. It has to be a both and. And at some point, we need to have a conversation that we learned from the oncology community around this idea that co-located services is something that patients want, that they need. I always say to people, it's very interesting to me that less than half of people who are postpartum attend their 6-week postpartum traditional appointment, but 98% of participants attend their first pediatrician's appointment. And there's some people who have been trying to co-locate those services to say, okay, we're going to see the child for their first peds appointment, but we're also going to see the pregnant person for their postpartum appointment, right? I actually really think we should be doing what midwives do. And they see people at postpartum day 1, postpartum day 3. I mean, we need different models of care, and that's actually the real reimagine. But in the now, there are small incremental things that we can be doing to actually mitigate harm and take a harm reduction approach now that we're in the land of Dobbs. So all that background was to get us here, right? I mean, how can we reimagine what's possible? First of all, any work that we are doing needs a collective response. So we have to connect everything that we're doing to a broader national landscape. I'm flying to DC tomorrow, but then I'm going to Atlanta to talk with, because I'm a member of the board of Black Mamas Matter Alliance. Black Maternal Health Awareness Week is coming up April 11th through the 18th. And we're really trying to change the conversation this year about justice and joy, and really trying to think through what's the connection with all the other national initiatives, all the regional initiatives that are going on, so we can have an amplified effort towards improving health outcomes. Because without that, I am fundamentally worried that, we're not going to see the kind of, change that we want to be able to see at a collective level. I also don't want us to act like there haven't been any wins, right? So the top line are states where we've either expanded abortion access, reproductive health access, PrEP, HIV care, trans care. And they're starred because either my work was cited or I was a direct participant in those cases. And so one of the other things outside of linking your work to the broader, national landscape is that we need to do some media training, rapid response, and we need to do some development of people who can provide evidence-based expert testimony in some of the cases to proactively achieve reproductive justice. It was a huge deal for me to work with the lawyers from the Lawyering Project in Minnesota to understand that we could codify, reproductive justice and reproductive rights, as well as abortion rights in the state constitution, and to really make the argument around continuity of care, to work with community organizers like Rebecca Polson and Professor Rachel Hardiman at University of Minnesota, who already had currency on the ground, who already had the trust and the relationships, knowing that Roots Community Birth Center in Minnesota it's more than a birth center. It's a community center. It is a hub. It is a trusted place. It's a social service agency, right? Working with the folks on the ground to really be able to say, this is what the citizens want. So I get very frustrated when we think about the negative of Dobbs, but we also don't look at some of the wins that we've had, some opportunities where we've seen some partners come together, like the National Asian Pacific Islander Women's Forum with the NAACP, right? When we start thinking, we have an opportunity to create some linkages that historically have never been made. And so maybe we need to be thinking about, okay, let's remember, if Congress wanted to fix the Dobbs situation, they actually could. We could pass the Women's Health Reproduction Protection Act, right? So what can we be thinking about or reimagine that we could build differently? What's the evidence base necessary to get us there? As researchers, as social scientists, as people who are engaged in the intersection between public health and clinical health services provision, we need to really be unlocking and thinking about the data elements that we want to be able to maybe see in future legacy measurements, whether it's the behavioral risk factor surveillance survey, BRIFIDS or PRAMS or whatever it is. We want to start thinking about what are the other kinds of wins that we can have, and what are the other kinds of scientific tools that we can develop to assist us in moving us to the evidence base, right? That we really, really want to answer some very vexing and hard questions. This exists. It existed before Dobbs. This blueprint for sexual and reproductive health rights and justice was developed by 90 organizations, entities, and institutions, where I'm going to show you the principles of this document. Is freely downloadable from the website Internew Voices for Reproductive Justice. And I believe the URL is in my slide set. But principle one is to ensure that all sexual and reproductive health services and care are accessible to all people, right? Both globally and domestically. We can think about people having access to facility-based birth, that we can have a qualified workforce and providers, that we can, begin to think about, sexual and reproductive health as just a normal part of physical health. And, doing that domestically and globally, I really think, and this requires advocacy. This also requires good evidence to show where we can improve health outcomes. And I also think there's a cost, benefit analyses that could occur here that I think is super relevant and super important. We need to ensure that discriminatory barriers, there's so many people talking about health equity right now, and people talking about, implicit bias and algorithmic bias and all of these things within healthcare, but we could end barriers to care for young people right now, right? We can decide that, people who are not insured actually can receive healthcare. We can, make different decisions about how we treat immigrants in sexual and reproductive health care and carceral settings. So, I think people, when we're thinking about solutions on how to operationalize reproductive justice, people get overwhelmed because we've been taught that it is overwhelming because we bought into this binary that people are so quote unquote polarized that we actually can't make movement. And I actually reject that. In fact, I fundamentally reject it because I have data and have conducted studies both of nurses and patients to show that like a large proportion of our population is in the middle. I like to call it the mushy middle. And I know that makes some people uncomfortable, but the truth of the matter is when you poll people, whether it's, Pew Charitable Trust or, public polling around abortion and family planning, contraception, drag queens and, trans rights and all of these other things, people have a whole range of ideas and thoughts and attitudes and beliefs that are really grounded in their own experiences. And so we need to be more nuanced. We need to trouble this discussion to really get at where those points of alignment that we can actually develop, robust social safety net and safety structures around improving health outcomes and quality that will allow us to move forward. We need research and innovation. I mean, I keep telling people one of the reasons why I moved to the University of Washington is so I could, engage with undergrads and, people who are earlier in their careers. I had 147 of them in my class this morning on health systems and health policies. We're starting too late in repro, right? It is a field that I'm still very excited about. It's a field that I think is very complicated because it brings in, upbringing and religiosity and science and belief and a whole variety of that. We need a lot of brilliant minds thinking about these very difficult issues. We're talking about the propagation of the human species and resource allocation and environmental justice and all of these domains, right? How do we ensure that our future workforce is not dampened by our current political environment? How do we make sure that people know that they can have successful and robust and community partner careers in wanting to improve maternal morbidity and mortality and infant mortality, and to make sure that people get dignified abortion care, and to make sure that infertility and surrogacy and all these other sort of complex ethical issues that we're working with, that we have good minds and good evidence to be able to engage with this content. I'm very invested in that future. I also think this is where behavioral and social science in my mind really matter. This idea that we have people, whether it's judges or elected officials, and some of us should also be thinking about engaging in those, politics and political tools, who need evidence, who need fact-based information, who need data. Our curiosity is wide in the field of sexual and reproductive health. And I think that as we continue to design studies, as we continue to describe phenomenon across populations, as we continue to think through, what we need in terms of training our future clinical learners and our public health scholars, I hope one lesson that we will learn is that we will translate our work to the public, especially for those of you who've been federally funded. Right? The taxpayers, in my opinion, have already paid for those data. They've already paid for that science. And so to then have our work sit behind firewalls that they can't access and or be in language that they don't easily understand, I think is a real problem. It's one of the reasons why I feel like the last 7 years I've almost exclusively published in open source journals, and that I've tried to use op-eds and commentaries and other things to translate those findings so that the public can really understand the nuance, the complexity of the work that we do. And I want more of us to really own that. So when we had a change in administration, the document that I showed you, to that blueprint, was actually updated again in 2020 to really look at what the priorities of the administration should be under the Office of Population Affairs, the Department of Health and Human Services, the Center for Disease Control and Prevention, the National Science Foundation, PCORI, and of course the NIH. And this document really gets at what were the priorities where we really, and the website is there, reproblueprint.org. You can download it. It's a beautiful PDF and it's like a book. And then there's an executive summary, but it really talks through not only what we should be working towards, but also the evidence that supports, the the clinical and political interventions that we were asking to be funded, right? Or the programs that we really, really wanted to see be highlighted. I still am an unapologetic advocate for an Office of Sexual and Reproductive Health and Wellbeing at the cabinet level within the administration, because I think that sexual and reproductive health traverses public health, clinical health services provision. It covers housing, transportation, the economy. It touches every aspect that sits at the advisory level. And so, health and human services, housing, urban development, even Department of Justice, criminal justice, right? I think it is one of those places, and reproductive justice gives us the analytic tools to be able to rationalize why all of that is the thing, right? If you have inadequate transportation and can't get to your healthcare appointments, it's not that you are a no-show or you're being, a difficult patient. You structurally are unable to get to your appointment. Or if you're experiencing food and or water apartheid, right? Because there are no clean, vegetables and fruits where you live. There is no clean water where you live, right? And so blaming patients and people around it, why can't we think about the structures that make that a thing? And then, really fix that. What are the interventions? Do we need to be sending people, basic minimum income to support families throughout pregnancy and childbirth, right? What are the interventions? What are the structures that we need to really get at to make significant change? Some of them are going to be retrofits. Some of them are going to be reimaginations. Some of them are going to be reformations. I keep saying, at some point, we're going to do some interventions with the people who do home visiting, whether it's nurse family partnership or First Five or the first 1,000 days or the public health department. Where can we build out a new robust, system that will be early detection for signs and symptoms of deterioration? I am very worried in the context of Dobbs that our maternal health crisis is going to worsen, right? And so when we think about that, because abortion has been so safe over time, that we haven't even collected abortion related, statistics around complications. The only database that I know of that's done that relatively well is Dr. Ushma Upadhyay at, Answer and, Caitlin Myers, where we've looked to track what those complications were, right? So we know that abortion is very, very safe, but I'm worried in the context of Dobbs that we're going to be missing places where we can intervene, or people are going to be so scared to do so because of criminalization. So as we think about that, who are the other people that we can make asks of, whether it's home visiting or, the American Hospital Association or, the Aspen Institute or the Institute of Healthcare Improvement? Where are the places where we are interfacing as scientists, as researchers, as clinicians, where we can make asks to assist us in creating a new, robust response for pregnant, capable people and the people who care for them, the providers? Where can we do that, right? I think we have opportunity division around that. Wrote this op-ed with Dr. Joy Perry and Asmara Gabri, who is a midwife at Zuckerberg San Francisco General, to really outline how to operationalize, some of these pieces that I've talked about. And we did this specifically for Black Maternal Health Awareness Week and Black History Month, Women's History Month. But one of the big things we also came back to, those of you who have hiring and firing authority, those of you who can hire clinicians, faculty member, staff, alumni, please, please, please be thinking about workforce diversification as an intervention in and of itself. Because I actually really believe we need new metrics to look at outcomes over time, not just with racial concordance, but really thinking about the intersections of coming from communities, that we serve, and really thinking about what those elements and what those mediators and moderators are to be able to improve care. Please be thinking about those things, because we have an opportunity to really be thinking differently about how we pull together our workforce. I am about to be very impressed by the first employer that says, because Martha Ryan from the Homeless Prenatal Program in San Francisco taught me this. When she started her organization, she wanted her at least 25% of people she had previously served to be her employees. How many of us on this call are willing to say and stake our reputation on the fact that We want 25 to 33% of the people who are currently working for us to be people that we previously served. I would like to see us take those kinds of metrics on, because we want to become the employer of choice for people who historically have utilized our services. I want to see those kinds of initiatives where we really invest in those kinds of pipeline programs. This came out right at the end of January as part of the commemoration for the death of Roe. And Sister Song, the Reproductive Justice Collective, put out this Visioning New Futures for Reproductive Justice. And it's a, you know, in my opinion, a very comprehensive document that talks about how we get to the actualization of reproductive justice, including, you know, abolitionist stances, including the demand for better data, including community engagement, including more oversight and regulation for things like, you know, artificial intelligence and other tools that we're perhaps relying on, and not really doing the hard work of building trust, of being able to, you know, engage with communities and to be able to support their own existing wisdom and learning. It's a very comprehensively, beautifully done report. Go to sistersong.net, and it's the first thing that comes up on the homepage. I highly recommend that you read it. If I remember correctly, I believe it is 7 pages long when you create it as a PDF, but right now it's HTML on their website and you can scroll through it. It is an incredible document, and I view it as a place to provide some accountability around our reimagining. I'm going to end with this quote because I think this is really important. I want some time for questions. I see the chats popping off as well as the Q&A. That health equity will be experienced, not achieved. Dr. Ryan Pettaway is at OHSU. I really admire and respect his work. Not only does he publish really great public health scholarship, but he also is a really great poet. And he's been publishing his poetry along with Dr. LeConte Dill, and they are just amazing. But when we set ambitious but attainable goals for the health of all humans, and we can work together to realize these goals, I am very, very much around curating spaces where health equity will be experienced by not only the people that we serve, but those of us who work in those systems, because I actually believe we have the brain trust to be able to do it. And this is not something, you know, as brilliant as I am as an individual, and so many of you are on this call, we're not going to figure this out by ourselves, because if we were, we would have done it already. It is a collective thing that needs to happen, and it needs to be supported. It needs to be funded. It needs to be well resourced with humans and space and time. And so I really am very much looking forward to your questions, your comments. I have some very specific things, especially for researchers, if you're very, very interested in wanting, you know, more granular retrofitty kind of things to do to get us to reproductive justice. One is to really publish some papers about what does harm reduction look like in the context of Dobbs, right? What can we be asking of professional organizations, of funders, of other co-researchers, of community, right? I just think that there are so many retrofits that we need right now. And I'm hoping that those of you who are really living in the team of Reimagine, I hope y'all got something really good, because, you know, I know Sister Song has some great stuff, and Sister Love and Sister Reach and many other reproductive justice organizations, but we need everybody thinking about how to retrofit, how to reform, and how to reimagine so that we can actually really operationalize reproductive justice in our lifetime. So with that, if you're a go away and come back person like I am, you can hit me up on socials. I'm myself everywhere. You see my handle below. This is my UW email address for more involved or serious questions. I'm going to take some now, and I thank you so much for listening. I'm going to start sharing my screen and ask somebody to help me with the Q&A.
Absolutely. Thank you, Dr. McLemore, for that phenomenal presentation. That was really, really fantastic. There are a lot of great questions and discussion going on. If I might start with one question from an attendee.
Yeah.
What are the scientific areas, methodologies, and measures that you think most need to be explored and developed to expand our knowledge base and advance reproductive justice?
Thank you. I appreciate the question. And I will say this, there's 3 fundamental things that we need to think about in the context of Dobbs. Number 1 is like time. We need to stop asking questions about early entry to prenatal care, and we need to ask more precise question, something along the lines of, y'all can wordsmith this, but like, have you sought care for this pregnancy? And if so, when? Right? Because if people spent a month running around the country trying to get a wanted abortion but didn't get it, they're not, stigma, shame, judgment, and blame is going to keep them from telling you that. So I think we need to ask more precise research questions around, like, and stop asking our research questions or our clinical questions about the outcomes of pregnancy, right? Because abortion is an outcome of pregnancy. Birth is an outcome of pregnancy. Miscarriage is an outcome of pregnancy, right? So let's stop asking questions about the outcome and let's start asking questions about the pregnancy. If we can do that, I would just be very happy. The other question we got to start asking is marital status. It was Dr. Joya Creer Perry who taught me this, that, you know, if you have two poor people who exist on the income of two poor people, they fall in love, they get married and have a child. Now you got three people trying to exist on income of two poor people. You're poor, right? So can we start as scientists and researchers to be a little bit more precise? Like, I know historically we've used these proxies for a reason, but reproductive justice is more about precision. It's about multiple futures. It's about really thinking through getting people the care that they need. So let's ask the questions that we really want to ask and stop using these proxies. Same around like income, household income. Separate that out. Don't just ask income from jobs, because in you know, minoritized communities or racialized communities, there are multiple sources of income that don't necessarily come from work. And so we have to be thinking about, there's some people who are gig economy folks, there's some people who live in multi-generational households, there's some people, you know, that I'm an auntie, I send people money all the time, right? And that doesn't get captured. So if anything, I want precision in our metrics when we start asking questions. This is why qualitative work is so important. Hear the language that the people we serve use, so that we can start and have them review your surveys, not just at the end when it's been developed, have them look at it in the middle, right? Pay them to do that. So as we are thinking about those are just some examples of some questions. But those of you like me who are academicians, work with your institutional IRB to make the argument that if you have co-researchers that are community members, that their effort needs to be appropriately compensated, right? If I can put my effort on a grant and I'm considered a scientific expert, but I'm working with experts by experience who are community members, I need to pay them an appropriate living wage. And that's not coercion, that's not a violation of justice or beneficence, right? It's not manipulation either. But like to have some stop language around this issue of, if people are experts by experience and we are asking them to participate in research, we need to start to rethink this idea of remuneration, compensation, all of those things. We need to rethink that. That needs to be hella reimagined. And then when we think about like our science and writing it up, publication, right? As a journal editor for Health Equity, I spend a lot of time, I added a desk reject and I review every paper. I read every one that is submitted before I decide to send it out to an associate editor, because I don't want to waste anybody's time. And we changed our information for authors so that, you know, we're no longer just publishing studies that compare, you know, different populations that may or may not be racialized, right? We're not like just straight publishing health disparities papers anymore. We've put in our information for, we need, whose definition of health equity are you using? Because you might be using Dr. Zinzi Bailey's, but you might be using Dr. Kamara Jones, right? Or, you know, you might be, you know, using some other definition of health equity that, you know, that needs to be in your methods section. You need a theoretical or conceptual framework that is guiding your work, right? I think that in and the Health Equity is a completely online journal. There's no print to it, right? So I can say this thing, right? Because like word limited isn't really, I mean, it's a thing, but it's not really a thing because we're not worried about pages in an actual journal. So when you're thinking through if you are a journal editor or if you write a lot for journals, please be thinking about the language that you use. Can we all agree on person first language? I automatically reject any paper that refers to humans by their race or ethnicity with no noun after it. So if you're using the word whites and blacks and all that, I get you trying to like shorten for word length, but that reperpetuates and erases the humanity of the people represented in those data. So so for me, there's so many conversations that we need to have about this, but I want to get to some of the other questions because I see that starting to blow up.
There are so many good questions here. I wonder if I might ask, I think a follow-up question to what you were just describing would be around the outcome measures that you would look to in order to determine that reproductive justice is being experienced. What are some of the individual, family, community, and structural measures that would indicate moving in the right direction or success? What does that look like?
Okay, so we need we need interim measure. I always say this, like moving things at the population level, like around maternal morbidity and mortality. That's not like, I'm not interested in that, because we're not going to see those population shifts until we see big shifts in like how we structure our society. And I know that pisses people off, but that's really how I feel about it. So some interim metrics that you want to look at as participants, if they would come back to your institution. As participants, what was the best thing they experienced when they were at your institution? Ask them what was the worst thing they experienced when they were at your institution. Ask them what about their experience would they have changed, right? To me, by asking these interim questions, we're going to get at collectively what are the elements that are necessary to design clinical health services provision from a reproductive justice perspective. Dr. Zoe Julian and Kwajalein Jackson at Feminist Women's Health, they hosted a whole session on operationalizing RJ in a clinical environment. Dr. Nakia Grayson and the Black Midwifery Fellowship at Choices, they have been working on operationalizing, reproductive justice in a clinical health environment for a while. When you think about what are the mechanisms where we would recognize reproductive justice, one of the other things I would say is, okay, are the staff and the employees representative of the community that they serve? Because if they are, that means you have future opportunities to join the health professions and future inspiration around employment, right? That just tells me there's a certain amount of seriousness in terms of moving the work forward. Or in terms of other like sort of researchable metrics, right? One thing I would look at is, have we developed new tools to use harm reduction approaches or mitigate harm, right? So one way I think about it is at the University of Washington, we just installed some vending machines around campus that have the emergency contraception, Plan B. We're going to be putting misoprostol, mifepristone. We have, ibuprofen, hot packs, and all the stuff that students can just come freely get. It's a harm reduction strategy, right? So there are people innovating, riffing around harm reduction strategies because they are proactively thinking that we don't need to be so patriarchal in how we deliver reproductive health services. Maybe. One other way of thinking about it is, are there touch points within your services, your organization, your institution, or your research for people to edit your tools? Right. I have been allowing, non-binary and gender non-conforming people to edit my language and my tools and research. I get that some of us are very tied to, we want longitudinal data. We want a survey that we can deploy over time. But inherent in that is not the idea of lifelong learning. And we all say we like to be lifelong learners. And that means your instruments are going to change as our times change. Your language will change as our times change. I'm so sorry I took so long to answer that question. I know there's a million other ones. If we're recording this, do you mind copy and pasting them to me and I'll answer them and then you can post that when you post my slides?
That would be fantastic. And
Great.
Thank you so much, Dr. McLemore. I'm going to turn things back over to Dr. Hunter to close out today's webinar. Thank you.
Yeah, I'm going to keep it brief because I know we're almost at conclusion, but just thank you very much. As we predicted, the Q&A was active and there's more questions than we could possibly answer in the time we have. Just a reminder to everybody that today's webinar will be available in about a month on the OBSSR website. I put that in the chat, so you should be able to see it. There's information about our next two events, the next OBSSR Directors webinar and the 16th NIH Matilda White Riley Honors event we have. Encourage you to subscribe to our listserv. And just again, thank you, Dr. McLemore, for accepting our invitation and for such an important and engaging talk. And with that, we will conclude today's webinar. And thank you to all the attendees. I hope you have a great day.
Thank you.